So this series of webinars is being offered by the Alliance for Patient Navigators, Community Health Workers, and Promotores de Salud. Overall, the mission is trying to reduce disparities in health, and it's trying to improve health equity among a lot of our underserved populations. And the purpose of the Alliance is to try to make these three roles, community health workers, promotores de salud, and patient navigators, all to have more sustainable positions. And so that's what some of these trainings are about.
Hey, Linda?
Go through some it's going to go through fast. Some is going to share a little bit about what's in the Yes?
Hi, sorry, you're it sounds like you're breaking up quite a bit.
I'm not even moving.
Yeah, it's the sound.
Would that be all right?
Let's see. It sounds good now. Now it sounds okay.
Okay, well, let's see if we can figure out what it is so that we avoid it in the future, and we'll do the best we can today. I apologize to everyone. Taryn and I are trying to get the technology issues all worked out. Okay, so anyway, the session will go through anatomy, facts and fallacies, some cancer data, some information from the Colorado Cancer Plan, some strategies that we can use to help improve and increase cervical cancer screening among underserved women who live in rural parts of Colorado. Of course, our minorities and all different special interest groups, people who are handicapped, gay, lesbian, well, it would be lesbian women. There are some transgender that also are eligible for cervical cancer screening. So anatomy to begin with, the uterus is just, the here is just where the uterus is located. We didn't used to show this picture, and this is kind of a heads up for all of you, because you're going to be working with women in rural areas. A lot of the women have not taken part in cervical cancer screening very regularly. And what we found out is that some women thought since they're old, that they thought they were higher in money. And so we show a picture to show how low in the organs are low. So the womb, of course, is where the baby develops. I'm not getting things to work. Okay. And the cervix is showing it's in the lower part of the womb, and it opens into the vaginal area. Now, one of the things to also caution you about is that a lot of people have the perception that the vagina is just like this open organ waiting to be filled. And it's not. The walls of the vagina are flat upon themselves. When a woman has sexual intercourse and she's excited, meaning it's not a forced intercourse, the vaginal wall actually vibrates. And when it vibrates, it creates more of an opening, and it stretches the wall so that it can receive the penis. So, but it's not always open, and some women think that it is supposed to, and that's why they get infections. So it's just a misconception that many people have. So you have two fallopian tubes, you have ovaries on each side, and the eggs come in through the fallopian tube. And basically, there's little hairs that push the egg through, and then it implants in the walls of the uterus. When you look at some data sets, there's a lot of misinformation that people have, that they see that there are uterine cancers and they think that includes cervical cancer. It does not. A uterine cancer is up here, whereas the cervix is here. It's a very lower part, of the organ itself. So if you look at a side view, This is showing the bladder. This is showing the ovary. The woman is facing this way over here. And this is the uterus, and this is the vaginal tract. And again, you can see here it's showing it where it is actually a flat wall together. And this is showing just this little part here is the cervix. So it's a very, very small portion of this. And some of the facts and fallacies: any woman who has a cervix can develop cancer. And it's found in all racial groups. A woman's chances of developing cervical cancer increase as she grows older, such as over 55. Some of us are older than that, but when the data or the scientists or the research looks at a woman older, but 55, most women have gone through menopause, and that's what they're looking at, is that the tissue changes when you go through menopause, and that's why being over 55, the risk gets even higher. So cancer is going to develop over time, and it's a result of a complex mixture of different factors. Who develops cervical cancer? It's anyone who has a cervix, but the biggest thing that we find is it's related to daily behaviors that we have, as well as environment within the environment. But what we call both lifestyle and environment are risk factors for cervical cancer. So this is not the type of cancer that's inherited from your parents. So if those of you who are on the breast session yesterday, it's not the same thing like breast cancer that we have genetic markers for. Many risk factors may cause cancer of the cervix, but they're going to be human papillomavirus. There's actually about 200 different types of human papillomavirus. 12 of those cause different cancers, not just cervical cancer. So you're looking at cancers that include cervix, anal cancer, oropharyngeal, meaning the back of the throat, including the base of the tongue and the tonsils, if somebody still has tonsils. It includes the outer vagina, and it includes vaginal. So HPV is not just for cervical cancer, which is so important. We find ways to control it in a better way than we've been able to up till really just the last 10 years. So the HPV infection, it's going to increase the risk. You have had multiple sexual partners throughout your whole life, or if you're having sex with someone who has had many different sexual partners. So once one partner gets infected, they infect the other partner. Some of the women get very upset because they get treated and their sexual partner does not, and they get reinfected. And this creates quite a difficult cycle. So the HPV, basically it screws with your immune system. It makes your body not as able to fight different infections. If you have had multiple full-term pregnancies, that is another risk for cervical cancer to do with the trauma of the vaginal area and cervical area, with the uterus opening up to give birth. That's a lot of trauma on the cervix itself, and more each time you give birth, it's going through a lot of trauma for every single birth. And anytime you are regularly having irritation to any part of your body, that becomes a likely site for cancer. Example, somebody who is a pipe smoker, the hot temperature of the stem of the pipe on their tongue makes them at high risk for tongue cancer. So this is why the childbirth issue that is tied in to cervical cancer risk, but really the rationale behind it is that if somebody has been using contraceptives for many, many, many years, like 20 years, they've probably had multiple sexual partners. That's where the logic comes in. The other issue that throws a lot of people off is smoking, smoking commercial cigarettes, and it really is exposure to the nicotine. So the vaginal tract, the cervix itself, is a little bit softer, moisture type of a tissue, and nicotine in the body actually affects that type of tissue, not just in the mouth and our affect in other parts. People say, well, I don't smoke vagina. Why is this in here? And it's nicotine systemic parts of the body and affect tissue throughout your body. Now, another risk, and this happily is less common than it used to be, it's if a woman DES while they were pregnant. Now, DES was out in the late 70s, so this is for older women because it was discontinued. This was for women and mothers wanted to make certain they did not have miscarriage and lose their baby. Just to help protect the well-being of the baby, realizing that both little boys and little girls born to the mothers who have DES that are most prevalent among little girls is cervical cancer. Among little boys, it's prostate. So it's both the males and the females with the sexual or. So the human papilloma is our biggest risk factor. And what we've got is there's about, although there's 200 different types, there's 12 types that cause all of these different types of cancer. So we talk about HPV tied in with cervical and maybe a little bit with head and neck with more recent research. But these others are just as important, which is why we're interested in the vaccine and trying to prevent these other types of problems from occurring. So we have an increased risk if you have had if you've had many different sexual partners, or if whoever you are having sex with has many different partners. And what many women have been frustrated about is that they go in through to get treated and their partner does not, and they simply become reinfected. So if either member of the group of the pair has HPV, both need to be treated. It's very important. Both need to be treated. So part of what HPV does is it compromises our immune system, our ability to fight infections, and that's very important because there's different things that we are finding HPV is doing, not limited to cancer. And many of this is tied into the immune system and other types of anomalies in the body. So if you have had many long-term pregnancies, you also are at risk for cervical cancer. And this seems a little strange to a lot of people, but think about the trauma that the cervix goes through by having to expand to allow the baby's head to get from the uterus to the vagina and out of the body. And that's trauma. Anytime your body is regularly exposed to trauma or irritation, that becomes a likely site for cancer. This is why for a pipe smoker, they have the hot temperature up the stem of the pipe, and that's why a pipe smoker is at high risk for tongue cancer, because the heat is constantly irritating the tongue. If there's been long-term use of oral contraceptives, sometimes it just doesn't want to work. Oops, let me go back one, sorry. And the logic behind this is that if a woman's been using oral contraceptives, say for 20 years, she has probably had multiple sexual partners. The data do not say the oral contraceptive causes cervical cancer. It's really that she's being exposed to HPV. But when you're talking to people, this is what comes up as a risk factor. And I hope that makes a little bit of sense. Now, smoking commercial products is another significant issue. And this is because nicotine affects the softer or
more mucousy-like tissue, such as what the cervix is comprised of. So it's not that, you know, you'll have people say, they look at you crazy when you say smoking. They're like, I don't smoke that way. I don't put a cigarette, you know, in my vagina. And of course they don't. But this is because the nicotine gets into your system and it affects this type of, I'm going to call it a mucousy type of softer tissue anywhere in your body. And that's why nicotine is important. Now, the other thing is that mothers who took DES, and this was primarily up into the early 70s. It was supposed to be taken off the market in 1971. So this is older women. But if the woman took DES, and the reason why she was taking it, it was to prevent miscarriage. So these were mothers who were very concerned that their babies were going to be okay. So by taking the DES, unwittingly, nobody knew that it was affecting both the little boys or the little girls who were born to her. The little girls, the most common cancer that they experience is cervical cancer. The little boys, it is prostate cancer. So DES had an effect on babies. We are also finding there's a whole new area of study that other things that women do during pregnancy is being related to other types of cancer too. So it's not just to DES, but right now for cervix, that's the most significant one. Now, there's also suspected risk, meaning there's a lot of controversy about how much this association is, or it happens just to be because we have some of the multiple unsafe behaviors causing multiple problems. Okay, so with this, chlamydia is a sexually transmitted disease. That's what the STD is standing for here, sexually transmitted disease. And this is HIV, which can be somebody who's infected with HIV or they actually have full-blown AIDS. When somebody has HIV, their immune system is so compromised. If you are exposed to something else, cervical cancer can be a common side effect. This is why it's only suspected. Chlamydia is the most common sexually transmitted disease that there is. And chlamydia, in general, has symptoms that no one would notice. And they think that this may also create almost a low-grade infection in your body that affects your immune system, which means you're not able to fight or protect your body against anything else. So another suspected risk factor is if you were younger than 17 at the time you had your first full-term pregnancy. What that is referring to is that when you are younger, your cervical tissue is more fragile. Sometimes we used to call it infantile tissue, but it's not from an infant. It's just that it's not mature yet. It's not ready to be pounded by a penis during intercourse. Where this is really important is if you have a young girl who has been molested or if she has been raped. If she, in either being raped at any age is another issue for cervical cancer risk because, of course, there's more trauma done to that young woman or that woman of any age who's a victim of rape. But younger than 17 and or having your first full-term pregnancy, you're looking at infantile or tender tissue that's more susceptible to irritation, to risk. It can be leading to regular irritating that part of the body that becomes the cervical cancer. I got that kind of screwed up there. I hope that made sense. Sorry. Then this is a question, and if we were able to do better with question and answer, the symptoms and what are the symptoms or the signs that may be related to cancer of the cervix. And the issue with cervical cancer, as it is with other cancers such as ovarian cancer, is the early stages, there are no symptoms. Now, as the cervical cancer develops, there are possible signs, and they may or may not appear, meaning that there are some women who have cervical cancer who have never had any signs or any symptoms that are on this next list. So it's unusual bleeding or a discharge from the vagina. The discharge may be a yellowish color. It may be a little bit light rust, which means it's blood that has been oxygenated. It can be almost a milky discharge, but most women, when they have some type of a discharge, they think they have a vaginal infection. And so it's such a common experience for women to have vaginal infections, they don't pay a lot of attention to it. They can have longer and heavier menstrual periods. So maybe their menstrual period used to last 5 days and now it's lasting 7 days. And maybe they went through 4 pads by day 3 and now they're going through 5 pads still on. So it's both heavier and it's longer. It also includes bleeding in between your periods or after sex if a woman has bleeding. Now, occasionally, depending on position or whatever, she could have hemorrhoids that while having sex, even though hemorrhoids are in the rectum, there can be enough pressure on it that you'll have bleeding. And you want to get them checked out if you are having bleeding to find out what it is. So hemorrhoids are a totally different orifice in the body. But there are women who have had that and they've panicked a little bit. We don't panic. You go to the healthcare provider. And your role as navigators is to help the women get to the healthcare provider. The other is if you have finished menopause, which again, most women have finished by age 55, if you continue to have some bleeding. And a lot of women say, well, I guess I'm still having menstrual flow. If you have gone through menopause and you are still having bleeding, that woman needs to get back into the healthcare provider and find out exactly why. The other thing is having pain, lower abdominal pain. So this, sometimes women say, well, it's like when I used to get menstrual cramps. Menstrual cramps are from the uterus actually going through contractions to get rid of the blood flow. Pain in the lower abdominal area, in particular, if it's after menopause, is not normal. And that's something else that you want to get in and find out, why am I continuing to have pain in here? Because there needs to be a reason for it. Now, there is the U.S. Preventive Task Force. That's what this acronym is standing for. They provide the screening guidelines that for most of your organizations, if you are following their guidelines, you can get reimbursed. Your patient does not pay for any of the cervical cancer screening issues. If you are not following U.S. Preventive Task Force, you may find that you've got women all of a sudden are getting hit with a bill. Now, if you're under the state's program, Colorado State's program, the WWC, that's supposed to help pay for breast and cervical screening, and you screen somebody, outline the preventive guidelines, you need to find out if they're covered. So don't assume that just because you have some funding from the state that every woman is covered. She is not. She is not. And that depends on your group and your relationship with the state and what you're allowed to do. Now, this is a summary of all different types of cancer screening risk. And what we're looking at today is just this first one on cervical cancer. Now, the U.S. Preventive Task Force changes their guidelines on what screening should be done based on research that is published in peer-reviewed journals. They changed it to age 21, which a lot of us who work with underserved communities, so my community is American Indian, we have the highest cervical cancer incidence rate of most other racial groups in geographic regions of the U.S. And I'll show you a slide that shows that in a minute. But we can't wait to be screened until we're age 21 for this. This is also true for other underserved populations, such as African American, young African American women, Latino women. This is actually a little bit late. And that's why I say find out from your local funding if you are screening young girls 16 and 17 years of age, are they allowed to be reimbursed? Does your program get reimbursed for their screening? And it may not. So check on it, don't assume. It stops at age 75 because by age 75, if you develop cervical cancer, that cervical cancer is going to be growing very, very slowly, and it's not likely to cause death at that age. So they find it's not really that significant to screen someone who's 76 or 78. And if your tests come out fine, if there's nothing abnormal in them, they allow you to do it every 3 years. I'm so used to asking for questions here. It's just difficult to not be able to have you ask what you want to ask. So a Pap test is done during a pelvic exam, needs to be by a trained provider in a clinic. And a Pap test can tell the woman if she has any abnormal cells or if it's cancer of the cervix. And if it's we're trying to get women where it's early stage of growth. This cancer, there's no reason for a woman to die of it. The treatments are too effective. Where women die is that they do not get into, they stop screening, and there'll be a slide on it and a few more slides up here. But a lot of women think once they've had their children, they don't need to go in for cervical cancer screening anymore, and it's not true. You still have to have a healthy cervix. And so it's very, very frustrating on here. Oh, here it is. Many women quit having Pap tests after their childbearing years. But older women, you need to have Pap tests too. And this includes if you have gone through the change of life. So some women will go through menopause at very young. There occasionally are women who go through menopause in their late 20s. And occasionally there's women who don't go through menopause until their early 60s. But most of us are done by the time we're 55. So there is a liquid prep test that many of your clinics are using. And you're going to hear when you talk to people, it's like, well, they're going in for a Pap test. A Pap test is not quite the same thing as a liquid prep test. A liquid prep test is excellent for finding HPV. If the woman is not at risk for HPV, you're looking at the difference of a cost of a Pap of about $14 as compared to the liquid prep test costing your program anywhere from $30 to $75. Now, if the woman is not at risk for HPV, a Pap is perfectly fine. Both of them require a pelvic exam, so they're still going to be in the same position. But the liquid prep test was very much a political issue so that laboratories could get more money for their testing. They had done a series of tests at Duke University trying to see the cost effectiveness, and liquid prep tests ended up costing an average of $75 more per patient because it led to so many false positives. But it brought in the lab so much more money. There were lobbyists that got it mandated in certain states. So if the woman is not really, I mean, and then she could have a Pap, and then if the Pap is abnormal, then she could have a liquid prep test. It means coming back in for a second test. But liquid prep does an excellent job of identifying HPV. I know that's a little confusing. And go ahead and write your questions down and let me clarify it at the end. Now, the Food and Drug Administration is who's responsible for approving different drugs, including vaccines. There are 3 HPV vaccines, and a vaccine means your body makes antibodies to fight infections. Now, your body at all times doesn't just say, oh my gosh, I'm infected, I got it, I'm done. Your body is always tries to fight. What a vaccine gives you more of an army to fight against the infection. So it really helps in a lot of ways. So Gardasil was the first one that was released, and then there's Gardasil 9. So it's kind of hard to see it next to the registered symbol here, but Gardasil 9, and then Cervarix. So these vaccines, and one of the things that's nice is the vaccines are getting better and better all the time, all prevent HPV type 16 and type 18. Remember, there's 200 different types. There's only about 12 types that are directly related to causing cancer. Now they think there might be a few more, but overall there's 12 we're most concerned about. So type 16 and 18 cause about 70% of all cervical cancer. Now I want you to think for a minute. We've been talking about the vaccine in public health as if it's a cure-all. It is not. You could have a Gardasil and you could have HPV, that's one of the other types that'll be lower on the slide, and there's still 30% of the people who can get cervical cancer. So the vaccine makes a very, very major cut, especially the newest version of Gardasil has made a major breakthrough, and there will be more, but it is not 100%. And that's important for people to realize, because women still need to behave in healthy manners. They cannot say, I've had the vaccine so I can do anything I want, because they are still at risk for this. Now, Gardasil also prevented HPV type 6 and 11, which is responsible for almost all genital warts, and that's really nice to not have to deal with that. Now, Gardasil 9 prevents HPV 16, 18, 6, 11, 31, 33, 45, 52, and 58. So what you got here is 4, 5, 6, 7, 8, 9. Out of the approximately 12 that were on the previous slide. So this is a major breakthrough, and that is why, as of May 2017, Gardasil 9 is the only HPV vaccine used in the U.S. Now that's important because some people they travel, they're in the armed forces, and so they're in different countries, and they get vaccinated for HPV, or their children get vaccinated in other countries. And it could be that their children were vaccinated only with Gardasil or only with Cervarix. And that means they're not as protected for this. So you need to help them understand and find out, what does the provider want them to do? Do they want them to get a different vaccine? And it varies. Some providers say, yes, have them be vaccinated again with the Gardasil 9. So who should get it? It's children age 11 or 12. The rationale is that they don't want the child to have been exposed to HPV before they receive the vaccine. Now, this is what they initially were recommending. But if a child has been a victim of sexual abuse, that child can also be vaccinated at a younger age. There are exceptions for those children who have been abused. Some children, ideally not too many, but some children do start having intercourse before age 11. And that means that they already may have HPV. If you're exposed to it, they're worried that it won't be as effective as somebody who does not have HPV in their body. So the recommendations is that you have 2 HPV vaccine shots, approximately 6 to 12 months apart from one another. It used to be that you had to have 3, but they found that 2 were working quite well. If you had them less than 5 months apart, then you need to have a 3rd shot. And it's because it takes time for your body to develop antibodies. And when we were first doing the vaccine, we didn't understand how long some of that was, and we were having people get the 3 shots within 12 months, and it probably wasn't as effective. So if they do a titer to actually see what people are protected against, they didn't have as much protection, which is why they changed how common and how frequently this is done. If it is a young woman up through age 26, they're encouraging her to do it. If it's a woman who's in her 35 or 40, you have to talk with your doctor. It's not within the guidelines because they're worried that she's exposed. An example of where they make an exception is that we had a young nun who left the nunnery and fell in love and wanted to get married, and her doctor allowed her to have the vaccine because as a nun, he figured she probably wasn't exposed to a whole lot of sexual intercourse. So there's always going to be some exceptions that are in there. Now, they're also doing vaccinations of young men now, and it's young men through age 21. The reason for the difference in age is that men tend to have more sexual partners than do women. And by age 21, most of the men have already been exposed to HPV. So they're trying to get them before they have many more exposures in there. In adolescents who get their first dose at age 15 or older, they usually need 3 doses over 6 months. So it's a little bit screwy on the patterns. And what our navigators do in our program is that they print out what some of this information is, and then they talk with the woman, about the vaccine, and then they make certain with the provider that they're giving exactly the information the provider feels is correct for your clinic. Now, there's other things about who should get the HPV vaccine that did not used to be included in the guidelines, and now it is. And that if somebody has been affected with HIV. So it means anybody who's HIV infected, they're immunocompromised, and they're not able to fight off any different infections. And so the healthcare providers want them to have as much protection as they possibly can. Similarly, if it's men who have sex with men, we'll call also as homosexual or bisexual or transgender up to age 26. Because we're finding that this is another group that we're getting an awful lot of penile, HPV-related penile cancer, and other types of head and neck cancer, and so we want to have them protected as well. If you receive the vaccine, so let's say it's a young woman, she got the first dose, then she discovered she was pregnant. They don't want you to get the second dose until after you deliver your baby. And this is just to protect the baby from unknown risks that we don't understand yet. We don't want HPV to become the next generation's issues with DES like we had from women in the 70s. So the best way to help oneself is to avoid HPV infection. So HPV causes genital warts, but for many women, the genital warts are inside the vaginal tract, so they don't know that they even have it. The other way to avoid HPV infection is have a limited number of sexual partners. I noticed in the chat box, somebody said how many is many, and what the science is, more than 4 partners is considered many sexual partners. Now, for a lot of us in different situations and growing up, it's like they have had that in their senior year of high school. But that's also why we're trying to promote the vaccine to kind of protect. So a limited number of sexual partners, and most people will get HPV if they have more than 5 sexual partners in their lifetime. This is not all at the same time, of course, it's over their whole lifetime. And sexual partners are likely to have the same type of HPV. So if your partner has type 18, you're likely to have type 18. But both partners have to be treated, because if not, you just continue to reinfect one another. And keeping in mind that men are also at risk for other cancers, such as the head and neck that were on the previous slide or earlier slide in there. You can use condoms to help protect yourself, but keep in mind, HPV can be present on the skin or the labia, the outer lips openings to the vagina, and that's not covered by a condom. And so you can still contract the infection. So again, it's not a cure-all. HPV vaccine is likely to eliminate most, but you still have to behave in a healthy way and be responsible in your sexual behavior. And anytime the women you work with are uncertain what they should do, make certain that you help them talk to their provider. So sometimes they're more comfortable asking you questions they want to ask their provider. In particular, a lot of women can't say the word penis, or they're too uncomfortable with it. They'll say dick or some other slang, but they don't want to say some of the different words that they really need. And they may ask you as a navigator to say the questions for them. And that usually takes some practice for some navigators. They don't have an issue with it, but others, if you do, practice saying them when you're driving in your car alone, practice saying some of the different words that you're uncomfortable with when you're in the shower, you know, and other situations. So you get used to saying them, and it's not like, oh my gosh, I'm saying that word or anything. So females need to practice good behaviors to prevent cancer of the cervix. So a Pap test about every 3 years, or as often as your provider suggests. So if you have not had an abnormal Pap, they may say come in every 5 years. Now the problem with that is remembering when you were supposed to come back, and that's been a problem with a lot of the changing U.S. Preventive Task Force guidelines. If you have a sexually transmitted disease, get treatment. If you are concerned that you have a disease such as chlamydia, help the woman tell her doctor that she needs to have some other tests to find out and to be treated, because you treat chlamydia frequently differently than you do some of the other sexually transmitted diseases. In tobacco, again, it's going to affect the nicotine that's in tobacco, affects those different softer mucousy types of tissues. So you want to reduce your exposure to secondhand smoke as well as to directly smoking. So the Pap tests themselves, I'm sure most of you who are on the webinar have gone through this, the infamous laying on your back. And what a Pap test does is it tells you if you have abnormal cells. If a woman goes in regularly, most cervical cancer, not all of it, but most, grows so slowly that you're not going to have an issue once with it being too advanced, because you have precancerous changes in your cells. And for most women, those precancerous cells are there for a few years before they grow into cancer. And that's why regular screening is so important. So if it's identified early, it actually can be prevented or cured. Again, there's no reason for a woman to die of cervical cancer today. This is a type of cancer that's very easy to treat. So the test is done during a pelvic exam, and it needs to be a trained provider, of course, who does it. And the woman, once they're 21, now according to the U.S. Preventive Task Force, are the ones who should have it. All women who are having sexual intercourse, and all women even after they have quit having children, and young girls who were molested or raped. And your provider will let you know when the patient can stop having it. So overall, it's about every 3 years, unless the provider says that they're obviously in pretty good health, they haven't had anything abnormal, and they don't have to have it except for every 5 years. And in that case, they'll do a Pap test with the liquid PrEP test to look for HPV. So many women quit having it after their childbearing years. And this is very, very difficult. And we find it's very common among my population, American Indian women. It's very common among Latino women. And it's fairly common among African American women. We don't see it being as much of a problem among white and Asian women. But you need to keep doing you need to have good cervical health throughout your life. So when you prep, you'll ask to remove your underpants. Now, if you are working with a woman who has been a victim of sexual molestation or rape, they may ask you to be in the room. You can also, instead of the woman being totally into the little gown or the little robe, she can keep her blouse on. And sometimes as a navigator, you have to talk with the providers and say, this woman needs to be handled gently, and she's very modest, and she needs to keep her blouse on. And most providers will go along with it. They don't want to see the woman traumatized. Occasionally you'll get an idiot. And then as a navigator, you try to protect your patient. You try to be there. We've had some of the women like to hold the hand of the navigator, and you just stand up by her head. So you're not seeing her private areas or anything, but you can be holding her hand and stand near her head so that she knows you're there. Women who have been victims of rape, our navigators have prayed with them during the test because they are so uncomfortable having their genitals touched by someone, male or female. They're just too uncomfortable for that. So some tips, if you can, you try to have it when you're not on your moon or when you're not on your period. You ideally do not douche, don't use birth control foams, creams, or jellies like 2 days before you have the test. And that's because there's residual amounts that remain in some of the folds of the vaginal walls and near the folds that are up near the top of the cervix, where the cervix is at the base of the uterus. There's little folds in there, and it can interfere with the accuracy of the test. When they scrape the test, if they get some of the dried up foam, they may think it's something that it is not. And ideally you have a lab that's not going to make that type of a problem, but we've had it happen to some of our women in Colorado. So you get on the table, you lie on your back, you have a sheet over the lower half of your body, and your feet are in stirrups, but the stirrups aren't shown in that little caricature that's up there. The provider will ask you to move your bottom to the edge of the table so that they have easier access to the vaginal opening. And you spread your knees, you're supposed to relax, and then they insert a speculum. Now more and more providers are being taught to warm up the speculum, warm water before they insert it, but they insert it and this little clamp pulls the walls apart. Remember, the vaginal wall, it's not just a big open, gaping organ. It is flat. It folds on itself, so it's very small, and they have to pull the walls apart so that they can get the Q-tip in to be able to brush against the cervix right here. And then they can also do a visual inspection, by the way, of the cervix, and they want to see it looking nice and healthy. This is fuzzy, but it shows you a nice pink, healthy cervix right here. That's what we like to see. So they try to gently collect the cells from the surface of the cervix. Sometimes they use a little wooden stick, other times it's a cotton swab, and other times it's a brush that they'll use for it. And they have to collect enough cells for a laboratory to examine. You will have some women who are told that their Pap test wasn't good, and the women are like, what, did I do something wrong? And that's not what it means. It means that the provider wasn't able to get enough cells in the specimen for the laboratory to read. If they only have a few cells, it's not a valid test. They have to have enough to be able to look to see if there's anything unusual. So they take the cells, the provider takes the cells, and they smear them on a glass slide, and that's what's supposed to be over here, just fuzzy. Here's another one showing it. I couldn't get a clearer picture of this, I'm sorry. And then they spray the slide so that it fixes the cells in place, and then they put another little slide on top of it. And they have to send it to a laboratory for examination. Now, as you work as a navigator, a community health worker, or a Promotore de Salud, if you are finding that you're having a lot of tests that are not coming out good, try sending the test to a different lab. It may be the provider is not collecting enough cells. The other thing is that some labs are very unreliable, and you have to be careful. You have to make certain you're getting enough, because you don't want to waste the woman's time and your time accompanying her back in for her appointment for nothing. So when the lab technicians, they have to see through the microscope how many healthy cells and if some cells are changing. They're not counting them, but they look at if there's anything unusual. In the laboratory, it's where a lot of errors occur in the past. inefficient labs, and we had false negatives. So women thought there was something wrong when there really was nothing wrong. So you have to be kind of vigilant about what the type of place where you go for laboratory care and so on. And then the laboratory staff send the results to the provider, and the provider and the staff from the clinic are supposed to notify the women. Now, women who have had a hysterectomy. Now today, if I go in for a hysterectomy today, they're going to take my uterus and my cervix most of the time, because I'm an older woman. I'm 70. If it was done, let's say 30 years ago, it was a different thing. You had a hysterectomy, but they left the cervix in. So if you're dealing with an older woman, you can, in the state program, the CDC program that pays for cervical cancer screening, they will pay for a pelvic exam to find out if she has a cervix. So if she does not have a cervix, there's nothing to test. She does not need a Pap test. If she does not have a cervix, if she does have a cervix, I'm sorry, then she can have the pelvic to do the Pap, and she needs to follow the provider's recommendations. And again, this goes back to, you're going to have some places that are going to say she must have liquid prep. No, liquid prep is to check for HPV, and again, it is quite a bit more expensive than as a Pap test. So kind of don't get caught into that thing of wasting. It ends up wasting money for your local clinical setting. So the test itself only takes a few minutes. It's not painful. You will feel pressure from the speculum, and the more nervous you are and the more you clamp your abdominal muscles or your Kegel muscles, you're gonna feel more discomfort because you're squeezing around the hard speculum. So that's why it's really, really important for you to relax. And so like this little woman, she's not happy, but she's also not in pain. And some women who are very nervous, in particular, again, women who are previous victims of a rape or child molestation, they may want to take some type of pain reliever before they come into the appointment. And others do relaxation exercises, or they pray during the exam. So why you should get a Pap test? It's to identify abnormal cells before they become cancer. It actually is one of the screening tests. Both colorectal cancer and cervical cancer are two of the only cancers that they really have prevention. So you can identify cells that are precancerous, which means they remove them, and there's different techniques for removing them, and you're not at risk. You don't have the bad cells anymore. So early detection of abnormal cells, it allows treatment before the cancer even becomes cancer. So it's precancerous, which is very important. So current screening rates and trends that we have in Colorado, there's an average of 150 cases of invasive cervical cancer diagnosed in Colorado every year. That's about 2 out of every 100,000 women in Colorado. Now, that's not a lot of women, but what it is, it's an unnecessary death because this cancer is so easy to treat. This is a good test. These screening tests are good. They find out things, and we can get women into treatment, and they don't have to go through the trauma of cervical cancer. And cervical cancer diagnoses, when it says are staying steady, it means we're not seeing them increase. In Colorado, we're not necessarily seeing them decrease. It's staying about 2 out of 100,000 women. So overall, there's an estimated 3,500 women in Colorado as of 2016. And these are survivors of cervical cancer. This is not talking about those who had screening done and they had precancerous growth. So the lifetime risk of cancer extends to up to age 85, that they quit screening at 75. But if you start developing cancer at age 75, you probably are not going to develop a death-causing type of cervical cancer. And a lot of cervical cancer is treated so differently now than it used to be. You know, it's like 40 years ago, when we had patients with cervical cancer, we treated them with cesium. Now, cesium is a radioactive substance, and it was put into women's cervix. Now, their cervix is right next to their large bowel or their rectum. It would deteriorate the lining of the rectum, the lining of your large bowel. And people would die because they would get poisoned from their fecal material leaking out into the abdominal cavity. Now, our treatments today are much more focused. There's internal radiation that is not done the way old radiation was on there. So we have much better treatments for this, thank the Creator. And this slide is just a summary of kind of talking about what's in the U.S. Preventive Task Force in a little bit easier to understand language. And this is showing new cases, and this is looking for all U.S. This is not for Colorado. This is all U.S. So the estimated number of new cases in 2018 were 13,240. That's 0.8%. Now, for those of you who were in the breast cancer session yesterday, I want you to kind of think back, what was the percentage of new case of breast cancer? And it actually was 15%. 15% is a long way. This is less than 1%. But again, this is totally treatable in early stages, totally cured. Breast cancer is getting better and better also in the treatment. So when we look at the percent survival in 5 years, it's 66.2. I just said earlier stage of diagnosis, right? Look at what happens if it's localized. Percent by cases, 45% of the women in the United States, not in Colorado alone, confined just to the cervix. This means it has spread to regional lymph nodes, which in this case, it goes to your groin. 15%, it's already metastasized, and 4 is unknown. All of these are totally preventable. Okay? It's totally preventable. It's very frustrating because this is a good test and there are good treatments for it. If you look at the 5-year relative survival, if it's localized, it's almost 92%. Live at least 5 years. The ones that don't are the ones who keep delaying going in for treatment. They don't complete the treatment cycle. That's one of the most common reasons for that remaining 7 to 8%. Actually, more 8. The regional, 56%. You can see that if it's already spread, if it's metastasized, only 17% are alive because it will metastasize to other organs that are near it. It will metastasize to the ovaries. Ovarian cancer is incredibly deadly. It is very difficult. We don't have a good test. All we have is a blood test, the CA-125. They're working on better tests, but there's no symptoms for it. We're also looking at what's right next to it, bladder cancer, kidney cancer, colon cancer. So you look at where the organ is next to it, and when it metastasizes, it typically will metastasize to the organs that are nearby. And that's why this is such a low level of survival. And the unknown stage means they don't know, they can't tell anything about where it, or how it, when it started, or how many cells were in it. So this is why screening is so important. So cervical cancer data, new cases of cervical cancer in the United States, it's 7.4 per 100,000 women. Now, remember in Colorado, it was 2 per 100,000 women. Colorado, we are one of the most healthy states in the United States, and that extends to our cervical cancer risk. But it also talks about how important it is for people such as navigators, community health workers, Promotores de Salud, to help women get into screening. This is why our figures are better than it is for the rest of the nation. And the number of deaths, 2.3 per 100,000 per year. You know, that's still, those are unnecessary deaths. And we look at, it's less than half, it's just about 0.5% of the women will be diagnosed with cervical cancer at some point during their lifetime, based on 2003 to 2015 data. This should be going down. In 2015, there were an estimated 257,524 women living with cervical cancer in the United States. Okay? These need to be get into treatment. This is showing how common is cervical cancer. These are the more common cases. This is the number of deaths, the number of new cases diagnosed. So you see breast, lung, prostate, on and on down. This is uterine cancer, is not cervical cancer. This is in the uterus. This is not. This is cervical cancer. Look at the difference in this number, 13%, as compared to some of these other numbers that are up here. So you're looking at 0.8%. It's a very small proportion, and again, no one should die of this disease. If you look at the difference by race, the average is 7.4. African American women are higher. So are my people, American Indians, Alaska Natives, Latinos, 8.9. They're the highest in this group. Now, but when you look at data, you have to look at it with a carton of salt. And what I mean by looking at it with a carton of salt is, again, I'm going to show you an example in, this one is showing deaths per year, per 100,000, I'm sorry. But this is looking at American Indian, and this is by geographic regions, like from Alaska, this is non-Hispanic white, Northern Plains. So the previous slide showed American Indian, Alaska Native incidence is 2.6. But look at those numbers. Those are way beyond that. And so we see that there are statistically significant increases in risk and in the rates of cancer in our community. We think this is likely to be true for other racial groups as well. So we just don't have all the information we want. And this is older data that's on here. The newer data shows improvements, but it's still, we still see the regional differences. And this is just looking at a different type of bar graph. And on this bar graph, the non-Hispanic whites are the red, and these are the American Indians from Northern Plains, from Alaska, Southern Plains, the Pacific Coast. So excessively high amounts. And cervical cancer by new cases per age group, the median age at diagnosis is 50. So look at what you've got here. Look at the span here where this is so important. And these are our screening, because we start screening at age 21 to 65. So we can be doing something to help reduce these numbers. And this is looking at deaths. So the median age at death is 58. So the women, the average age for being diagnosed is at age 50, and they live for 8 years with cervical cancer before they pass on that. So again, you can kind of see the age ranges that are in here. So the younger women also. It tends to be about 8 years for a lot of the groups. So some strategies that you can do, and this is from the Colorado Cancer Plan. They want to increase high quality guideline adherent cancer screening rates among average risk individuals. Most of your women are going to be average risk. And what they encourage for strategies is to educate providers about cervical cancer screening guidelines, including when to conduct HPV and if it should be done in conjunction with a Pap. That's what co-test means, that it's not just HPV alone. Now, for most of us, we're looking at being community patient navigators, some clinical navigators, some nurse navigators, some social work navigators. Our providers don't necessarily think they need to be educated by us. So this is a little bit of a challenge. But if you develop a good relationship, they may listen to you a little bit more all the time about what else you can do they can be doing, because they don't want to see women experiencing cervical cancer either. And for screening, you can be promoting the benefits of doing the different types of tests with your population. The other thing that you can do is you can implement a client reminder system, whether it's print or phone. Now, for a lot of our women, even though they're using more and more phones, some of them ask them if they would do text messaging. A lot of them will use phones mainly to Facebook with their children or their grandchildren. So you have to kind of work with them and find out what is the best way for you to remind the women you're working with, rather than just thinking a phone call. Many women don't have landlines anymore. And print, it's too easy for things to get mixed up in the mail and not have as much of an impact on someone unless you're handing it to them directly. And you can tailor the messages so that it's appropriate. You want to be alive to see your daughter graduate. Show your daughter how a well woman behaves. We find this technique of doing one-on-one and group education, we typically do it by our navigators in our community. Trained health professionals are fine. We do use them. Linda Krebs and I both help out with these types of trainings, but in my opinion, our navigators, our promotores, and our community health workers are even better. We help answer questions that our other staff do not. We call our navigators native sisters. When they can't answer it, Linda Kay or I come in to answer the questions. And the people really pay attention because they trust our navigators, our native sisters. The other thing is promote the benefit and the increased, not just that you go in for screening, but if something's abnormal, that you get the follow-up you need. And that is where patient navigation is so essential. A lot of these women are too nervous to go back into the clinic, and with the navigator, you cross the threshold together and you're with the patient going in for the follow-up care, and it makes certain they get in for an earlier diagnosis. And then you want to try to support the training of more navigators, more community health workers, promotores, and you want to develop teams. You want to reinforce one another. The social work navigator is absolutely invaluable. Social workers know things about resources that a lot of us know a few things, but never to the depth that most social workers do. Develop a team with whom you work so that you can help the women get into the care in a timely manner. It is 3:21. I know that you missed sound in some of the initial 12 or 14 slides. I would like to open it up for questions, and I'm wondering, Taryn, can they type their question into the chat box and then I can respond to it?
Yeah, absolutely. You guys can use the chat feature as much as you'd like.
Okay, questions about anything? Nothing. And we still have 22 people on. Anything at all. And nothing embarrasses me. You can ask me anything. Okay, nothing embarrasses me. Been around the block too many times. Okay, if you think of something that you want to ask, I gave my email at the beginning, but it may have been garbled since we had so many sound problems. My email is lindab at NAT, like the first 3 letters of native, AM, the first 2 letters of American, the word cancer, CANCER, .net. So lindab at natamcancer.net. Okay, and Taryn is, oh, thank you. Taryn is letting everyone know about some of the other classes, and it will be recorded and posted on the Patient Navigation Training Collaborative website. and anyone can access it. Again, anything that you think of later on, send me an email. When I'm out in Indian country, I don't have internet access, so give me a few days to respond. Okay? And I'm going to go ahead and, oh, well, thank you. Getting a lot of very lovely comments here. The other webinars that are coming up, apparently it's the same Zoom access. I did not know that. That's why I was having trouble at the beginning. I wasn't getting on Zoom correctly. And our next Tuesday will be on lung screening. Next Wednesday, a week from today, is on colorectal cancer. And the following Tuesday will be on prostate cancer. And then after that, we have a few weeks break. And then we're going to have Rebecca Ritchie focus on advanced motivational interviewing skills. Now, for any of you who have not had motivational interviewing for a while, or maybe never, the first 3 webinars of motivational interviewing are supposed to be on the Patient Navigation Training Collaborative website. You can go through and review those, or you can go through other self-training. There are motivational interviewing self-training classes, but so that you get the basic skills. So there actually is eligibility to take part in Rebecca's, and that so that she's not going through basics, she can emphasize the higher level skills for motivational interviewing. She will have one-on-one follow-up with those who want it, for those who go through the advanced sessions also, a limited number, right? Same link for Zoom for all the webinars for everyone. Thank you all. Thank you for taking time.